Hi, just wanted to give you a little bit more information on pacemakers. I know there's been a need for education on pacemakers, and I know many of our staff, especially our newer staff, are not comfortable with them. We're going to be discussing temporary pacing. We will see them in our open heart population. Most of our open heart patients will come out with pacing wires, but also too we'll see them come from cath lab with temporary pacing wires for things like heart block, pauses, symptomatic bradycardia. Okay, just wanted to quickly go over the conduction system of the heart. As you remember, way back when you were in school, it starts out, if the person's in a sinus rhythm, it'll go from the sinus node to the AV node to the bundle of His and then down the Purkinje fibers. But one thing you want to keep in mind is not only look at your monitor, take a look at your patient. You can have a beautiful paced rhythm on the monitor, but if you don't have mechanical capture, it doesn't do you any good. And what I mean by mechanical capture, make sure that you feel a palpable pulse when you see the paced rhythm on the EKG monitor. This slide shows what it would look like if the patient had a permanent pacer, where the leads are. You can have a ventricular lead, an atrial lead, or both. The picture on the right shows where they're placed with an open heart patient. Our open heart patients have been mostly coming out with just ventricular wires recently, but some will have atrial and ventricular wires, and if they have the atrial wires, they'll be on the right, and then the ventricular wires will be on the left. When the patient comes back from cath lab for a transvenous pacer, you will see that the transvenous pacing wire is thread through a single lumen introducer, or sometimes we call it a cordis. Now you want to have small volume fluid going through the side port of the cordis, usually about 10 cc's an hour. You just don't want a large volume of fluid going through there. Also, you will see at the end of the transvenous pacing wire a syringe with a lock similar to what we have on our swans. You want to make sure that that lock is off, just so someone doesn't inadvertently inject through that. So this slide explains when we talk about the different types of pacemakers, whether it's a DDD, a VVI, this explains what that means. So in a DDD, both the atria and ventricle are being paced. And then the second D means both the atria and ventricle are being sensed. And then the third letter is dual, and that means the impulse can either be triggered or inhibited depending on what the pacemaker senses. So this is what a DDD pacer will look like on your rhythm strip. Sometimes you'll also call it AV paced. You will have a little pacer spike and then a P wave, and then the second pacer spike, and then the QRS. Some of the permanent pacers will say DDDR, and that is a rate responsive pacemaker. Your pacemaker is able to sense when you have a higher heart rate that's required. For example, if someone is increasing their activity, they may need to have a higher heart rate, so the pacemaker can adjust that. So this rhythm strip shows what a VVI pacer will look like. the ventricle is paced, the ventricle is sensed, and then it will inhibit a spike if it sees the patient's own rhythm. So you see the pacer spike and then the QRS. The next slide shows a rhythm strip of an AAI mode. The atria are paced. You see the pacer spike and then a P wave, and then the patient has their own ventricular rhythm. So you only see pacer spikes that correspond to the P waves. Okay, let's take a look at the pacemaker box that we use for the temporary pacemakers. These look a little different, but they're very similar to our old ones. At the very top right, you see the green box that is the on-off button. And then underneath that, you see the 3 dials that correspond to the pacemaker adjustments. The top one controls the rate. Here you see the rate at 80. The second one controls the output if you have atrial wires. That currently is turned off, and you can see how it's a little faded. The third dial corresponds to the ventricular output, and you can see that there at 10. Underneath that third dial, you see a little key, and you have to press that in order to make any adjustments on the pacemaker. You see right next to the key, there's a little lock symbol with a point to the key. That's currently telling you that the pacemaker is locked, and you need to unlock it to make any adjustments. Now looking at the second half of the pacemaker box, the lower part will open up some additional menus. The first one you see is the sensitivity, and that's right next to the green arrow. Here the ventricular sensitivity is set at 2.0 millivolts. The other extra menu you may see is the mode selection, and to get to the mode selection, what you would do is you would go down on the white arrow till you get to your mode selection. Now when you go down to the next menu with the mode selection, you can see here it shows a VVI. To select your VVI mode, you will hit that green arrow. As you can see, the green arrow and the arrow next to the VVI box look the same. Once you press it, it's selected. Okay, let's talk about the pacemaker battery. When you're looking at your pacemaker, the battery indicator is next to the key symbol, and you can see how much battery life you have left. It's a good idea to check the battery indicator every time you're assessing your pacemaker settings. You will go through the battery quicker if you have high pacemaker settings. In order to change out the battery, there is a little button at the bottom of the pacemaker box, as you see on this slide. You press the button to pop out the batteries. We use 2 AA batteries, and then you just put them back in, and then you close the little slide and make sure it clicks. When you're changing out the batteries, you do have a pretty good amount of time. I actually popped out the batteries and waited to see before the whole box went dead, and I had over 3 minutes before the box went dead without the batteries in the machine. So next let's talk about capture. Capture is when the pacemaker sends a stimulus to the heart and creates the polarization of the cardiac chamber. To simplify it, you have a pacer spike and then you see a QRS. Just a bit of a warning, just make sure not only do you have a pacemaker spike and a QRS, but also make sure you have a mechanical capture. Make sure when you have the pacer spike and the QRS, you can actually feel a palpable pulse. So on this slide, we're going to talk about stimulation threshold. We want to make sure we have enough power, or MA, to create a QRS from the pacer spike. When we're looking at this slide, we have capture on the first three complexes, and then on the fourth pacer spike, you see the pacer spike, but not a QRS. So we want to know how much power does it take to consistently give the QRS from the pacer spike. Next, we're going to talk about pacing thresholds. The pacing threshold tells you what is the minimum amount of MA or power that it requires to create a paced beat. Now, you don't want to check your pacing threshold if your heart rate's greater than 100, because you could send them into tachyarrhythmias, or you don't want to check their pacing threshold if they're 100% pacer dependent. So what we're going to do is you're going to set the rate of the pacemaker at least 10 above the patient's own intrinsic rate. So if the patient's heart rate is 70, you're going to turn it up to a rate of 80, and you'll see them 100% paced. What you will next do is you'll slowly decrease the output. So you'll go down on the MA until you lose the capture and you're no longer 100% paced and the patient has their own intrinsic rhythm. Then what you do is you start slowly increasing the MA or your output until you get that 100% paced again. That will be your threshold. Then what you're going to do is you'll put your pacer settings back to where they were. What you want to do is you want to make sure you have your output or your MA. I've heard different things. I've heard 1.5 to 2.5. I've heard 2 to 3 times the amount of the stimulation threshold, just so you have a little bit of backup in case you suddenly need your patient's pacemaker in a hurry. Okay, so let's practice and look at it with the actual strips. So here your patient's pacemaker settings are a VVI of 60 with a MA of 10 and the sensitivity of 1.2 millivolts. The rhythm, as you can see here, it looks like a beautiful normal sinus rhythm. Okay, so now what we're going to do is we are going to turn the pacemaker rate up to 80. And when we do that, you can see that you're 100% paced. And then what we do after that, we leave it at a rate of 80. We then now adjust the MA. It's the third dial from the top. You're going to start bringing down the MA. You go down, 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 keep turning it down, and then when you get to an MA of 2, you see you've lost pacer capture and you are at a sinus rhythm. That is not your pacing threshold because you may have been a little overzealous on turning the MA down. So now you start slowly turning the MA up. At a MA of 3, you still have sinus rhythm. At an MA of 4, you now see you're back to 100% pacer capture. Your pacing threshold is 4. So when you're looking at your pacer settings is set in MA of 10. That is actually 2.5 times what your pacing threshold is. You should be fine. Okay, so why is it important to know your pacing threshold? Let's say over time you're needing more and more MA or more and more energy to produce a paced beat. You want to make sure that you let your physician know that it's requiring more MA, so when you're in an emergency situation, you do have a pacemaker that will work. Okay, let's talk about sensing. Sensing is when the pacemaker sees the patient's own rhythm. And it's important because you don't want the pacemaker to fire in a vulnerable period and cause arrhythmias. Now this is expressed in millivolts. This next slide shows a good visual of the fence. When we talk about pacemakers, we use a fence analogy to help us figure out, is the pacemaker too sensitive? Is it sensitive enough? Okay, so here is undersensing. This is when the pacemaker doesn't see the intrinsic beat, and here you have pacemaker spikes where they shouldn't be. So if you look at the third pacer spike, you can see it's pretty close to the T wave. It did not see the patient's own QRS. So what we want to do is when we see something like this, we want to lower the fence so you can see more of the patient's own rhythm coming through. So let's say your patient had a sensitivity of 2.0. What you would do is you would decrease the millivolts from 2.0 down to 1.5, maybe 1.0 until you stop seeing that. Okay, so this next slide talks about oversensing. This is something we don't see as much, but it is important for you to know about. So basically what happens is the pacemaker thinks something else is the patient's own intrinsic heartbeat. Maybe the patient has hiccups, burping, or something else like that the pacemaker says, oh, I don't have to do anything. So when you're looking at this slide, you see the paced beats, and then you see a sinus beat, and then in between those two sinus beats, there's quite a long pause. There should really be a paced beat somewhere in there. So what's happening is the pacemaker is seeing way too much, and you want to limit what the pacemaker is seeing. So you increase the fence, you raise the fence so it is more selective on what it sees. So what you're going to do is, let's say your pacer setting for your millivolts is set at 1, you may want to go back up to 2.0, and then the pacemaker will be able to know when it needs to truly go. Okay, so looking at fusion and pseudofusion beats, basically what this is when the pacemaker is doing what it needs to, it first senses and says, oh, I need to produce a paced beat. Then it produces that paced beat. What happens is that fusion beat, it's happening in that time frame between when the pacemaker realizes it has to do something and does something. So you can see it's pretty close to around the QRS. It is not in the vulnerable area that can set the patient into arrhythmias on the T wave. Okay, troubleshooting the pacemaker. Your pacemaker is not working right. So start with looking at the connections. Start from the patient and work your way to the box. Make sure all your connections are tight. Check your pacemaker battery. Do you have enough battery power? If it's an issue with the box, replace the box. Do you need to adjust your MA or sensitivity? We just went over that. And also too, what's going on with the patient? So is the patient having electrolyte abnormalities? Do you need to replace your potassium, your magnesium? Is your calcium low? So that may help. Also too, if the patient's acidotic, that may also cause problems with pacer capturing. What about, is the patient edematous? If their heart is edematous, there's extra fluid for the pacemaker impulse to go through. It may not work as well. Some things that you can do to, especially in a patient that has a transvenous pacer, you can turn the patient and see if that will help with the capture. Also, too, if you're not getting pacer capture with the pacer generator and you've tried all these troubleshooting things, you can always put the pacer pads on and pace them transcutaneously. So we have our intensivists. They can always help us troubleshoot our pacemaker and help us with the next steps if our pacemaker are not working. So this slide here shows you where to chart your pacemaker and settings in Epic. And this is where we would put it on the report sheet so we can communicate to everyone what our settings are, and also don't forget to put your pacing threshold on there if you have it. Okay, so now let's take a look at a couple of practice strips. So this first strip, when we're analyzing the strip, take a look at it, and is it atrial, ventricular, or dual chamber paced? If you take a look, you see one pacer spike and then a QRS, one pacer spike and a QRS. So this is a VVI pacer, ventricular. And next question you want to ask, is this appropriate pacing? And I would say yes, because you have a pacer spike and a QRS all the way through the strip. Okay, so let's look at this next strip. Is it atrial, ventricular, or dual chamber paced? It is ventricular because you see pacer spike, QRS, pacer spike, QRS. The next question we want to ask, is it appropriate pacing? The first three complexes, yes, because you have a pacer spike, then a QRS. The fourth one, you have a pacer spike with nothing afterwards. So what you want to do is you have a failure to capture. You want to give the pacemaker more power, so you're going to go up on your MA. The next slide we're going to look at, I want you to think atrial, ventricular, or dual chamber paced. When we're looking at this, it is atrial paced because you see a pacer spike, and if you look very carefully, you see a P wave after the pacer spike. You see a QRS, but there is no pacer spike before the QRS. So this is a AAI mode. Now the next question is it appropriate pacing? Yes, because after every pacer spike, you see a small little P wave. And does it need to pace on the QRS? No, because the patient has their own intrinsic beat. So this is appropriate pacing. Okay, this next strip that we're looking at, we're going to take a look. Is it atrial, ventricular, or dual chamber paced? It is dual chamber because you have a pacer spike, P wave, pacer spike, QRS, all the way through. Now the next thing is it appropriately pacing? When you have a dual chamber, it is helpful to think of it as two separate pacemakers. Look at your atrial pacemaker first, and then look at your ventricular pacemaker next. Let's look at the atrial. Is it appropriate? Pacer spike, P wave, all the way through. So yes, the atrial is appropriate. The ventricular, let's take a look at that one. This is a little trickier of a strip, and this strip has been passed around quite a bit with some of the pacemaker in-services we've had. But you see pacer spike, and there is a bit of a delay before the QRS. So technically that is not appropriate pacing. Technically you do have a failure to capture because the pacemaker spike is quite a far distance from the QRS. So what you would want to do is you would want to go up on your power or your MA. Now, if you had the pacer spike and then the QRS right afterwards, that would be appropriate pacing. But like I said, this is a strip that has been passed around, and this one is a little trickier. Okay, here is another strip to look at. This one is also a little bit tricky, but it's one of the other ones that's been passed around as kind of one of the classic ones for a pacemaker in service. Now, is this atrial, ventricular, or dual chamber paced? It is dual chamber. When you look at it, the pacer spikes deflecting upward, that is the atrial. The pacer spikes deflecting downward are the ventricular. They are a little bit hard to see, but there's some important things to point out on this strip. So when you're looking at the atrial, you have pacer spike, P wave, pacer spike, P wave. And you can see that best in the first two. The third one we'll come back to later, but it's easiest to see in the first two. So the atrial is pacing and sensing appropriately. Now let's look at the ventricular. The ventricular is the spike deflected downward. Where we really see an issue with it is we see it in the third complex. When you look at the third complex, you have a pacer spike after the QRS. So that is a problem with sensing. The pacemaker does not see the patient's own intrinsic beat. So you want to adjust the sensitivity. Because the patient's own intrinsic beat is there and the pacemaker does not see it, we want to lower the fence and bring the fence down so we can see more of what is going on with the patient's own beat. So this is a problem with failure to sense. Okay, we're going to look at this last slide now. So when we take a look at it, is it atrial, ventricular, or dual chamber paced? This is ventricular. You see pacer spike, QRS, pacer spike, QRS. So next thing is it appropriate pacing? Look at the third complex. I would say no. So what this is the pacemaker is not seeing the patient's own intrinsic rhythm. When it is a problem with seeing, it is a failure to sense. So what we want to do is we want to lower the fence so we can see more of what is going on with the patient. So let's say your pacer settings are, the sensitivity is set at a millivolt of 2.0. So what you'll do is you'll adjust your sensitivity to maybe a millivolt of 1.0 or 0.8, and hopefully that should get rid of the inappropriate pacing, and that should help your patient with the sensitivity. If you have any questions, you can always ask one of the heart nurses or one of the PCLs. And of course, we've got our intensivists who can be a great resource. And if you are having problems with your pacemaker, it would be a good thing to loop them into just to be another resource and communicate with cardiology if needed. Thank you.